Okay, I think the jingle was our signal to start, if the desk can just confirm. So wonderful. Okay, thank you so much, and good evening to all who are joining us here in person in Gastein, and greetings to all who are joining us online. And this is the last session after a long, very full day, so we really appreciate you taking the time to be here with us this evening. And I'm really honored to be joined here by distinguished speakers and panelists, and by the audience to have this important conversation about vaccine hesitancy. My name is Alison Mawson, and I'm a program manager at EuroHealthNet. EuroHealthNet is the European Partnership for Health, Equity, and Wellbeing based in Brussels. We work with national public health institutes, local authorities, research centers on questions of health equity and addressing determinants of health. And I'm also joined by my fellow EuroHealthNet colleague and young Gasteiner, Lina Papartite, who's at the news desk, and she's going to be supporting us over the next hour. And the other very important participant in this discussion, we hope, we know you're maybe tired, but we hope you're ready to engage. That's you, our audience. And so I'm going to already ask our colleagues from the EHFG if they could put our Slido questions up on the screen. So one more round of Slidos for the day, if you will. Okay, so here's our first question, and this is just top of mind. There's not a right answer. We want to know what you think. Who's to blame for vaccine hesitancy? What are the first reactions that come to mind for you? So, okay, social media, I see one, thank you. Any other thoughts? You don't have to be shy. Governments. Fake news. Intransparent decision-making. Nice. Myth, fascism, misinformation. Oh. Wow. Fantastic. Thank you. These are really, interesting. And I can leave it open for just maybe 10 more seconds. Fake news, I see coming really big. Misinformation. But fantastic. Difficulties in access. Distrust of establishment. There's lots here. We could have a whole session just on this slide. Okay, but we have a few more questions for you. So I'm going to close this one, and we'll go to the next question. Okay, so we want you to rank, what do you think are the most common barriers underserved communities face when accessing vaccines? So I'm not sure if you're able to choose several or choose one, how the question's structured, but if you can only choose one, what do you think is the most important of these? Okay. All right, I see the bars starting to slow down a little bit on their movement, but it's really great to see how they move. Limited time for healthcare professionals and patients to discuss vaccination. Lack of access to vaccination services are our leading topics. So, okay, maybe 10 more seconds. All right, so thank you so much for those responses. We've got limited time for healthcare professionals and patients to discuss vaccination. Now we're going to do another quick round. We've got pop quiz for you, and there are 3 questions, but the overarching question is, you have to choose which one of these roots or these psychological dispositions is most responsible for the statement above. Like if someone says, vaccines are intended to harm disadvantaged groups or poor countries, is that a religious concern what's the psychological root of that? Hopefully I'm making sense of my question. Okay. Running neck and neck here, distrust and conspiracist ideation. Okay, we'll give you the correct answer in just a minute. Okay, so maybe we can show what we would say is the correct answer, though I think, does it show answers? Let's see. Oh, it didn't show. Okay, well, we will talk about it. That's going to be Angelo's field, so he will go through this with you. So here's another one. Powerful groups oppress the disadvantaged by imposing vaccination. What kind of attitude root would you consider this to be? Okay, we'll spend another 10 seconds, and we have one final question like this one. Okay, let's go to our last question. Science and scientists belong to a malign elite group opposed to ordinary people. Yeah, the elite. Okay, this is fantastic. Thank you so much for taking the time to go through those questions with us. And again, we will be talking about those things, and we didn't see answers on the screen, but we're going to be discussing this right now with Danielle and Angelo in just a minute. I'm just going to say a few words to kick us off now. And I hope, by the way, that you'll continue to use Slido. Please send in questions, reactions, comments. Lena's going to be tracking that for us, and we'll pick them up during the Q&A. And that's, of course, if you're here in person or online. So the title of our discussion is, Are we having the wrong conversation about vaccine hesitancy? And as I think you saw in the responses to that very first Slido poll question, it's a very complex concept, although it is one that we like to simplify by pointing fingers and assigning blame. But really, it goes much deeper than that. I think we can all agree that it goes much deeper than that. And today, what we're going to do is we're going to talk about some of these deeper roots that we've identified that underpin vaccine hesitancy and some of the specific barriers that are affecting attitudes and vaccine uptake, particularly in some underserved communities. And I think everybody in this room is very aware that we need to close the gap in vaccine coverage across Europe. And a lot of times, the reason for that gap is assigned to vaccine hesitancy or vaccine inequalities. But I think during this session, what you'll hear is that we're arguing that vaccine hesitancy, in many cases, is a type of inequality. And it's an inequality that's grounded not only in the health system, but also in our history, in our politics, and in our society. And the most effective solutions that we can put forward to address vaccine hesitancy go well beyond individual decision-making and blaming individuals to really looking at addressing systemic injustices and structural barriers that are faced by people and populations across Europe. And so something that was positive, or I somehow see it as positive because we identify it as a problem. There's been a lot of talk already in the conference today about trust in government. And we all know that trust in government, as we find in these reports that are coming out, is a key enabler of high vaccine uptake. We're seeing that more and more. And there have been a couple of great reports. I'm going to reference one that the WHO released in July this year, Transforming the Health and Social Equity Landscape. And they found that people on a low income had 40% lower trust in government than people on a high income, for example. We also saw in another recent OECD report that there's not a simple correlation of vaccine coverage with trust in government, but there is a correlation between trust in government and susceptibility to other sources of information. So if you don't trust your government, you may be more vulnerable to accepting sources of mis or disinformation. And so another important point in this space is the amount of politicians who are starting to use vaccination as a wedge issue. And I think that's less of an issue in Europe than it is in the United States, for example. But it's leading to a further deterioration of trust in institutions, and it's politically stratifying vaccine coverage across, in this example, in the US, but I think we're seeing similar things across the world. And I think another part of this, looking broadly at political inequalities experienced by entire populations. If we look at countries in Eastern Europe that lived under communism or in the post-communist era, or we look at minority populations across Europe, like marginalized Roma communities or migrant populations, those inequalities have generated very deep distrust that has broad influences on the way that people decide to interact with government services, whether or not they want to accept or access health services, for example. And I think we often see behavior change as a solution that many policymakers and authorities like to recommend for lifestyle factors. People will say, well, people should stop smoking, or they should have a healthier diet, or they should be more physically active. That's very convenient to say that this is what people should do. We also say something similar about vaccine hesitancy. Well, people should just not be hesitant. They should not listen to misinformation. But health behaviors and vaccine decision-making are grounded in bigger, wider determinants of health, which would be our economic opportunities, our physical environments, and our social settings. And so we can't really look at those health behaviors or vaccine decision-making as primary causes. We should look at them as proxy indicators of something deeper, something happening under the surface. So today, what we really want to do is take that vaccine hesitancy conversation a bit away from the individual, off the individual, and off of these proxy indicators, and look toward those primary causes that are underlying a low vaccine uptake. And we want to talk not about who's responsible for vaccine hesitancy, but really what, and what can we do about it. And with that, I'm very, very excited to have our speakers here who are going to be speaking about some findings from 2 research projects that are funded by the European Union. One that's been looking at underserved communities across Europe, and another that's looking at understanding anti-vaccination arguments and how we can really address those. So both very relevant research and some very specific tools that we can use. And having said all of that, I'd now like to welcome our first speaker, who is Professor Danielle Janssen, an associate professor, medical sociologist, and head of the research program on integrated care for vulnerable children at the University Medical Center of Groningen in the Netherlands. And her research focuses on assessing and improving health system functioning to meet the contemporary healthcare needs of children and adolescents. She is the coordinator of the RIVER-EU research project, which is focused on reducing inequalities in vaccine uptake in the European region by engaging underserved communities. So having said this, Danielle, thank you for being with us, and the floor is yours.
Thank you, Alison. Welcome to you all. I'm very glad that you took the time to join this last session today. In the following minutes, I will lead you to RIVER-EU. It started about 2.5 years ago, and we are at the middle of the project, so I can tell you already what we have achieved. We started RIVER-EU by exploring health system barriers. And we do that in several underserved communities. We have included the migrant population in Greece, the Roma population in Slovakia, female with a Moroccan and Turkish background in the Netherlands, and the Ukraine-speaking population in Poland. And we started to explore the health system barriers very broadly. So we looked into the literature, but we also had several interviews, focus group discussions with the people themselves to find out what the barriers were. At the same time, we also looked at enablers, because there are populations in Europe that are deprived and normally underserved, but regarding vaccine uptake, they have a high vaccine uptake. For example, the Bangladesh population in the UK, Somali population in Finland, and the Arab Muslim population in Israel. So we also asked them, what helped you in making the decision to vaccinate your child? And the health system barriers, well, you also indicated what you thought the health system barriers were, and there's a lot of overlap not only overlap in the health system barriers, but also in the enablers. And what you see in the health system barriers is that people from underserved populations experience a lot of communication problems. They often do not understand the text. They do not understand why vaccines are there, why they should take the vaccine. They find difficulties in communicating with the healthcare professionals. In the population with a low vaccine uptake, there's also a low trust in healthcare professionals and a low trust in the governance. There's often a lack of initiative to raise public awareness. We found 19 different health system barriers, so I cannot mention them all by head, but these are the most important. And also a lack of information system in some countries in which it is impossible to find out which families or children are vaccinated and which families not. When you look at the enablers, you almost see the contrary. The people that we ask for the enablers indicated that they have a very high trust in healthcare professionals and also in the government. That was the most important enabler, I think, that was mentioned. They often had healthcare professionals from the same background as they are, so they were understood and they could discuss some cultural sensitive topics with them. They also took the time, they were very friendly, so these enabled them to get their vaccine. So the second step in our research was to find out if we want to address those health system barriers and take into account the health system enablers, what kind of interventions should we implement in those countries? And we did a realist interview to find promising intervention and also to find out why they worked. And then we had a list of promising interventions, and we had a research group that dived into the transferability of the interventions, because an intervention that is working in France does not mean that it also works in the Netherlands or in Greece. You have to meet some requirements for the interventions to be effective. So we now have a list of interventions that suit the countries, the governments and the organization of care of countries. And you see that most of these interventions are multi-component interventions. So not only targeting, as Alison said, the person itself, but also targeting, for example, healthcare professionals. For example, one promising intervention is about having a mediator, a health mediator, preferably with the same background as the people that you want to target, that goes into the community, talks with people, and answer their questions, and have a very reliable relationship with the community. And at the same time, for example, in the Netherlands, we have a good education system for doctors, but communication with people from a different background is not well organized. So in the Netherlands, we also will focus on how can we educate healthcare professionals better so they are prepared to talk and to understand people with a different background. So in the remaining part of River EU, we want to implement the intervention, and we do all the steps with the members of the underserved communities and also with the organizations, because we want that if the intervention is working in our country, then it is adapted by national organizations that have a responsibility in the vaccine uptake. So that is what we will do in the coming years, and we will collect the results of the interventions in guidelines and also in an educational platform for healthcare physicians. So that is River EU. If you are interested, please contact me or go to the website, and then you will find more information. And we are planning publications on all different vulnerable populations.
Thank you so much, Daniela. And I think it's really encouraging to see, somehow it's simultaneously frustrating and encouraging to see these are things, many of these solutions are in our grasp. You know, these are things that we can do. So I think it's really nice to have the research behind it and to see how we can put that into practice. And one of the things that I think is quite important in the findings of River EU that now links us very nicely to our next speaker, Angelo, is the importance of training healthcare professionals and making sure that they can have culturally sensitive communication and conversations with their patients. And so with that, I would like to welcome our next speaker, Dr. Angelo Fassi, who is joining us from the University of Coimbra. He is a philosopher of science with experience conducting psychological research on anti-scientific conceptions. And currently, his main line of research is focused on how to address anti-vaccine arguments in medical consultations and helping develop various tools and training programs in the framework of the Jiu-Jitsu project. And Jiu-Jitsu, if I'm not mistaken, is Jiu-Jitsu in the age of COVID. What's the full name? Yeah, so the full name of the project, but basically it's very long. Yeah, but it's about jiu-jitsu and basically using the strength of your opponent against the opponent, right? So yes, exactly. So you'll tell us all about that movie, huh? Thank you.
I'm going to talk about the Steven Seagal. Thank you. Thank you for having me here. A philosopher. I'm a weird animal in this conference, but I'm representing the Jiu-Jitsu project. Our main goal is, we have 5 nodes in 5 European countries, 6 nodes in 5 European countries, plus Canada. And the main goal of the project is to develop an intervention we call empathetic refutational interview. It's a conversation between the patient and the physician or the healthcare professional, tailoring the specific psychological dispositions of the patient and affirming and showing empathy instead of, well, it's a debunking strategy, but without a confrontational attitude, right? So we have developed a psychological taxonomy of anti-vaccination arguments. This taxonomy is in the website you can access with the QR code. And it's in English, French, German, Spanish, and Romanian. And we have validated this taxonomy using NLP, natural language processing algorithm, survey-based studies, and also a very in-depth literature review of scientific studies. And you will find 11 attitude roots or psychological dispositions that are manifested as anti-vaccination arguments. Among these are conspiracist ideation. The first example was a conspiracy theory. The intention to harm is a form of conspirational thinking in which there's a hidden plot with an evil intention. Then distrust toward the government, the physicians, the healthcare authorities, and so on. Also towards scientific research and the underlying values and norms of scientific research. The second example was distrust, the example about oppression. I can understand it also involves ideological component, especially some ideologies in the left wing using concepts such as structural oppression, but we classify that as distrust. Unwarranted beliefs that encompasses a broad range of pseudoscientific beliefs about natural remedies, natural immunity, alternative medicine, also links between vaccines and autism and many conditions. Worldview and politics. The third example was worldview and politics. It's a form of populism in which the medical community is represented as an evil outgroup. This is typical of populistic worldviews, which there's the common, well-intended, normal people in opposition to, well, there are many forms to call this common, well-intended common people. In each country is different, but yeah, it's a form of medical populism. Religious concerns, also concerns about intervening in God's will, violation of dietary norms, moral concerns, for example, regarding the ethical standards of scientific research on vaccines or the use of fetal cell lines in the production of vaccines. Fear and phobias, fear to side effects, hot lots, and there's some of these side effects are real, some of these side effects are the product of disinformation. This total risk perception, in which the risk of the vaccine is perceived as outweighing the risk of the disease itself. One of the most interesting things of the psychology of risk perception in the case of vaccines is that they target, it's a preventive intervention over a healthy population. They are mostly used on healthy people, and for disease that most of them have never seen. I have never seen a polio or a measles, a person with polio or measles. Well, maybe many people have lost contact with these diseases and they don't know how devastating they are. Also, epistemic relativism, over-reliance in personal anecdotes, intuitive thinking, maternal instinct, also postmodern understanding of expertise and the denying of the concept of truth. Some of these are very philosophically charged, and obviously very tricky to address in a doctor's consultation, right? To talk about the nature of truth with your physician. And also reactance is a very well-known psychological construct. It's the unwillingness to do what you are told to do. Right? That's very typical of children when they have to go to sleep and they don't want, and they are reactant. And we also include 62 themes classified across these 11 attitude routes. Some of them are very relevant or directly linked to marginalized population, which are the main focus of this session. For instance, themes related to unethical experimentation or biased data, like vaccines are not tested in my population, are tested only on male whites, or also concerns about your own tradition or the rejection of modernity among some populations. Religious exemptions are also, not allowing religious exemptions is perceived as discriminatory among some religious minorities. Also, concerns around vaccines as a form of targeting the disadvantages, tracking the population, sterilizing population, or depopulating. These are very common myths in some countries, in African countries. Also forms of alternative to medicine, traditional medicine, traditional remedies, faith healing, and so on. We have tested these interventions, these empathetic rebuttals. You will also find 62 empathetic rebuttals for each, one for each of the themes, 62 in total, on the website. And we are testing the effect of these rebuttals in online experiments now, so far. And we have observed very positive impact, especially on the satisfaction of the patient with it, after the interaction with the physician, willingness to keep the conversation, willingness to go back to the consultation to keep talking because they feel they are being understood by the physician. And we are now conducting field testings in Germany, France, and Romania. And we expect to see like the real effect in more naturalistic settings, but it's a very promising intervention for sure. Yeah, that's all I think. 1 minute more than, sorry. Yeah.
Thank you so much, Angelo. And I have to say, when I first came across Jitsuvax's work, it made the whole concept of vaccine hesitancy feel a little bit more like a game, that I could say, okay, but now, what kind of statement is that? And then how would I address that if I were the healthcare professional? So maybe we can put you on the hot spot for just a minute, and we can actually do an exercise of empathetic refutational interviewing. So I don't know if anybody on the audience wants to throw out a concern that maybe they've heard, or some sort of a statement like the ones you saw on the screen, and you can.
Hello.
Yeah, you can pretend that you're the you're the healthcare professional. So we didn't prep this. We didn't we didn't practice
this
for
is
this.
a trap.
It's a trap. Anybody want to throw out a? Yeah, please.
My favorite was
Because? As a philosopher, I must ask because what?
or why do you hesitate? Or why would you hesitate? Or what's the reason?
Why
I asked. No,
that's what you will ask to the patient.
Yes, I work. I'm sorry, man. I work as a GP, and of course, I come across that topic quite frequently. And my favorite answer to I was asking a patient, "Are you vaccinated?" In this regard, it was the COVID-19 vaccine, and I said, "Okay, any specific reason?" Because.
Yeah.
Reductants?
No,
I tried to go deeper. Didn't work. I can tell you.
Yeah, the first step of the empathetic refutation interview is eliciting concerns through active listening and open-ended questions. This is typical of a motivational interview as well, but motivational interview doesn't include the refutational component. It's more about listening and affirming. We're a bit more combative than that. And yes, the thing is that some patients are reluctant to speak their minds, so you have to build a relationship of trust and show empathy. I'm not here to judge you or to make fun of you. And yeah, that demands a range of skills, like, for example, emotional contention. Because sometimes, you can hear very extravagant arguments, and you have to just hear them and understand them and show how nice you can be.
It was just it was just an example. I usually do what you say. I ask, okay, what's the reason? And sometimes I mentioned it to some people yesterday. Why wouldn't you pick up the MMR vaccine for your kid? I'm afraid it's going to get autism. And I told her, if this is the one single concern you have, I can tell you here and now, please put it off the table. Get it out of your head. You don't have to be afraid of that. And this day, a few days later, she came back and she wanted to ask me about other vaccinations. So it can help. I just wanted to tell you, as an example, where would you put it? I thought that was the idea. Because to me, it's something of this blind reactance that you mentioned in the first start.
Yeah. I think there's another.
Hi. My name is Raquel. I'm from Portugal too. I'm a public health specialist. Hi. So the hardest question or hardest argument I had with a patient was because, and this is very rare, fortunately, in Europe and specifically in Portugal, was because one of her sons had died with diphtheria. I believe it's also diphtheria in English. Had died, and now she the mother didn't want the second child to be vaccinated because the first one was vaccinated, but vaccines are not 100% effective, unfortunately. So I had a really tough time deconstructing the argument, and in the end, the patient actually decided to do the vaccine, and it was for me, it was very successful, but it was very hard to deconstruct. Thank you.
Yes, these arguments around fear are very difficult to address because fear is an emotional reaction. It involves a cognitive component. Of course, there's a causal illusion. There is confusing correlation with causation, right? But there is also an emotional reaction, and you first have to address the emotional response, and once the person is calmed down, you can address the cognitive component. But there are also many people with just phobia to needles, for example, and it's very difficult to convince. I have phobia to needles. I'm vaccine hesitant, and sometimes people just need a hug. And maybe the way to address my vaccine hesitancy wasn't maybe talking, but giving me moral support. I'm here. in this case, yes, you need to show a lot of empathy because this person has passed through a very traumatic experience. There are many people who are hesitant because of past medical negligences, for example. Medical negligences exist, and these people, they don't trust doctors anymore. And it's very difficult to rebuild the relationship, and it's not going to work in just one session, but through a series of sessions and conversations, you can, as happened to you, and it's a very happy ending, you can solve the problem.
Yeah, thank you so much. And those were great impromptu questions from the audience. We really appreciate it. Lina, I know we're a bit past our schedule, but we're going to be fine. We'll keep to our schedule overall. Are there any project-specific questions that you've got online that we should direct to our speakers before we bring up our other panelists?
Yes, there is one to Angelo. So it says that great to see a tool for healthcare staff. And how was engagement amongst healthcare professionals for the philosophical behavioral approach?
The engagement of HCPs?
Of healthcare professionals.
They are very interested in the tool. The feedback we have received have been very, very positive. We had problems with the language at the beginning. We needed to adapt it to the language of HCPs. I wrote some of these rebuttals. I have a professional alienation sometimes with the terms I use. It's normal. I come from a different field. But yes, after some revisions, they are very, very satisfied. Yeah.
Thank you. And the other question is related to what Daniela said, but I think it also goes to what our next speakers would be talking. So that great examples of practical interventions that can be overarching themes pulled out for reducing inequity in East as well as West of Europe. So what are these overarching themes?
Yes, in River EU we deliberately choose countries and settings from the East and the South and the West. So we hope with our examples that the knowledge that we gained and also the knowledge about the interventions is transferable and generalizable across countries. And that was also the wish of the European Commission. So the interventions might be implementable in other countries, but I think you always have to find out to what extent it fits to the needs of your own population, because there are differences. And that's also what we see in River EU. The main intervention is more or less the same, but there are nuances, some small differences in parts of the interventions.
Wonderful. Thanks so much to the speakers and also to Lina. And now I'm very pleased to invite our other two panelists to the stage, and we are going to have more of a free-form discussion with you in the audience. So first, I will welcome Dr. Caroline Bollers, who's a senior advisor at the WHO Representation Office to the European Union. She's an experienced public health professional with thorough knowledge of WHO and the UN system, and she's worked for WHO in all of its levels, at country, regional, and global levels, and in technical and enabling functions. I will also welcome Dr. Mira Dasic, who is, amongst many other things, the head of the Secretariat of the Southeastern Europe Health Network, or SEAN, and she's worked as a medical doctor and specialized pediatrician for more than 2 decades, and has also served in various roles with WHO Europe, as well as within the government of Montenegro. So we thank you both very, very much for being with us now. And I thought what I would do is maybe start with some specific questions to the two of you. But again, we really please send more questions in, and I'm going to go around with a microphone after this, so get ready. But first, maybe to Mira, I wanted to ask you a little bit about your work within SEAN, within the Southeastern Europe Health Network, because that network, for those who aren't familiar, it started in 2001, immediately following the end of conflict in the Balkan region. And to bring that network together at that particular moment in time, when there had to be such intense distrust between the various public health institutions in those republics. How were you able to use, now it feels like health is a bit of a wedge or a political football that we throw back and forth. But at that time, it seems you were able to use health to rise above distrust and bring people together. So are there lessons from that experience starting the network that could be relevant for us today and for this discussion?
Okay, thank you, Alison. Good evening. It is my honor to be able to represent the Southeastern Europe Health Network. And yes, you are right. The Southeastern Europe Health Network was established as a peace-building tool to provide the communication among the member states that were in conflict in 2001. At that time, some of the representatives of the member states did not talk to each other. However, since health is a human right and necessary to maintain even during conflict times, slowly through dialogue, communication was restored. I would like just also to mention that in the republics of former Yugoslavia, the vaccination rate was quite high because they followed the vaccination calendar that was mandatory. So in general, up to the first cases of autism allegedly associated with MMR vaccine, and afterwards with the COVID-19 epidemic, the vaccination was performed according to the schedule. It is also worth mentioning that before the war, Yugoslavia was producing its own vaccines in Torlak. So in the general population, there was no doubt about the efficiency and quality of the vaccines. If we are looking at these times more than 20 years ago, I can say that the setting was completely different. And maybe I can also mention that during my 10-year period, when I was working as pediatrician, I was supervising the vaccination of school children according to the calendar. So the vaccination rate was high, and at the time between 1990, I'm talking in 2000, we were lucky as the healthcare workers were really trusted. Vaccination was mandatory. There were no anti-vaccination groups. There were no internet. And I have to say that the parents at that time were keen to make their children safe from known diseases, which today is not always the case. How can I say? I cannot say that we improved very much, because now the situation, especially for my colleagues, I think it's not so easy.
Yeah, thank you. Thank you for that. Yeah, it's discouraging, no, to see that things were, even in the midst of a very important conflict, people were able to see the importance of health, and now there are conflicts, but in places where there is not currently conflict, people aren't able to agree on that. So it's, yeah, it reminds me as well that producing own vaccine, there was a concern, I remember, with flu vaccines, that they were made using cells from pigs, and a lot of people, there was a lot of information going around that it wasn't halal for people to receive this vaccine if they were Muslim. And it was when they actually started producing a version of that same flu vaccine in Indonesia that people were then willing to have it, because it had been developed in a majority Muslim country. And they said, well, okay, if it's been developed by my colleagues who are also Muslim, then I can trust that I can have this vaccine. So I think there is something interesting there, maybe a learning that some could still have relevance in having production locally. So thank you very much. And Caroline, I wanted to also follow up on this issue of trust, because I mentioned this report from WHO finding that trust is related to health outcomes. It's interesting, WHO is a normative agency, but you do engage with the highest level of politics. And I think what I'm curious to know is, how do you encourage politicians to take up the recommendations from WHO, but without becoming political yourselves, without being perceived as a political institution? You talked a bit about some of these things this morning, if people were up at already at the Global Health Diplomacy session. I think there's some interesting follow-on we can have here on vaccines. So.
Yeah, thank you. I was just going to say, well, I don't know if I completely disagree that now in WHO, as I was saying this morning, I think we are more aware that trust is not a topic that we take for granted. We are aware that this is a continuing of, we need to build trust in the health system, in the whole ecosystem. The same thing in WHO. That's why we're trying to say people need to become more diplomatic savvy. They need to understand how can we build this trust. So of course we in WHO, as you rightly said, we follow our normative guidance. So we work with headquarters, and of course in the region we work very closely with the member state to understand what is going on, engage in different European projects. But I would say that what I understand, and I have to take here the credit for my colleagues in Copenhagen, Siddhartha Datta and Rob Butler, and also Catherine from the Behavioral Insight, because I'm not a vaccination expert, but I understand that the whole topic of vaccine hesitance is reframed according to vaccine acceptance and demand. So this is where, when we heard earlier to talk about enablers and barriers, this is where we want to shift the conversation with the politicians saying, or the policymakers saying, this is not the individual responsibility, this is a government responsibility. But how can we solve, this issue? One of the, flagship initiatives of the WHO European region has been this European immunization agenda. And in this agenda, one of the emphasis there is, if you want to address vaccine inequalities, you have to go local. You have to work at the local grassroots level, and you have to work with the local authorities, of course, together with the national authorities, but really to change this trust and go closer actually to the community in itself. And we have seen some positive examples of this engagement of the vaccination immunization agenda. I think examples in Finland, where they go out with mobile teams, then examples in the United Kingdom and Germany, where they do targeted communication advocacy campaigns, or in other countries where they use different techniques to really extend on the topic of trust and confidence. So I think that's one thing that I would say. Another reference is also the awareness to work with the younger generation, and to start much earlier on. So not just focus on the people who are making the policy, but trying to understand what do young people think, and how can we as WHO, together with other institutions, of course, integrate, for instance, a vaccination topic in the curriculum of schools. So there's also, I think when I was reading about it, I was thinking, because I'm still now, I shouldn't say Paw Patrol, but this immune patrol project that is going out to schools and trying to, build it as part of the school, so people, teachers and young children also get part of it. And I think also one thing that is important, it's a bit more boring, but we do have an indicator now in WHO that monitors the vaccine inequity, and this indicator is in fact targeted at what we call the third administrative unit, so the local level. And this allows WHO, together with, of course, UNICEF and the local and the national governments, to monitor how vaccine, uptake is going on. And we've seen positive, a slow increasing uptake of this indicator. So I think that's at least a good positive sign to conclude. I think that will be presented in Astana at the end of this month. Well, next month, I suppose. Thank you.
Thank you so much. Yeah, that's great. So I'll be very curious. Again, that's another topic we've seen quite a lot today, and I think we see in all of these conferences is, do we really measure? Are we really tracking this information? So to have that indicator is great. Lots of things I would love to pick up on from all the interventions, but I want to now go to Lena again and see if we have some questions on Slido, and then I'm going to start roving the floor if people would like to raise their hands. I see a hand over here. Lena, maybe you first if you've got something.
Yes, you can also see them put up. So there are two groups of questions. So one is related, is linked to what Daniela said about the Ukrainian speaking group in Poland. So have their attitude had any impact? Has the war had any impact on the attitudes towards vaccination? And then to Mira is if the communist heritage is, in a way, was an advantage for the high vaccine uptake, so why not having the mandatory vaccination nowadays? I don't know if I should go to the other questions or...
Or if you want, no, I think, do we want to take a couple, maybe we take a couple questions from the audience and then people can take, as long as people are taking notes and they know what questions we've already heard. Yeah, so you have a microphone. Okay. And also walk around with this one. I think, I saw your hand first and then maybe we can come to a colleague here. Thank you.
Hi, hello. Francisco from European Junior Doctors and also pediatrician. In line with what Carolina was saying regarding the activities for children, for instance, or our projects reaching children. I think in many of these discussions about hesitancy, we have been addressing healthcare professionals, we have been addressing media, but we many times are forgetting two special sectors, the education one. And it's not only about producing materials or introducing the curriculum, but we need to involve the teachers in this process and we need to train them as well. Otherwise, we can have a problem then about myths later if they are not trained in the message they are trying to pass to their children. And then we have, in the perspective of long life vaccination, the people who work in the social sector in the elderly care facilities, who can also promote vaccination in that special group. And these people who are not directly healthcare professionals need some training on this as well. And I think this is a topic that has not been covered as much as this topic in healthcare professionals. And I'd like to know your perspectives or projects that you may know about this. And thank you for the session and for the fruitful insights.
Thank you so much. And can we, and I see, there are two more hands over here. I think you've got the next microphone.
Yeah,
yes.
Hi. Is it? Yeah.
It's on, yeah.
My name is Nathan. I'm a health systems researcher from the European Observatory. I had a question that goes directly to Mira, actually. So you spoke about how in the late 90s, early 2000s, in these times of crisis and war, even then the parents were committed and dedicated to getting their children vaccinated. That generation are already grandparents or soon becoming grandparents. And so do you see a way to leverage them and that their grandchildren, they see that is somehow being looked at differently by their children? Is there communication intergenerationally that's going on related to that?
Thank you. And maybe let's take the two more I saw here. I think I saw another hand go up, but let's take these two more, answer, and then we can come back around because otherwise we'll forget some questions, I'm afraid. So, yes, please.
Good evening. Anne-Sophie Travat from the French Ministry for Europe and Foreign Affairs. So during the COVID-19 crisis, we have seen how some part of West Africa was sometimes influenced by the vaccination choices of France. I was wondering whether we had observed the same issues within Europe, so certain countries and population being influenced by the choice that maybe Western countries or neighboring countries were having in terms of vaccination, and whether this was also applicable between social classes. So, for example, certain social classes being influenced by upper social classes. Thank you.
Thank you. And let's take one more, and we'll come to the panel. So, yes, please. And I see. Oh, I think I saw your hand first. I'm sorry, but we won't forget you. Please. Do you have a microphone?
Aber having the wrong conversation about vaccine hesitancy, that's the meta theme, okay? All figures show that the hesitancy is because of fear just to have a vaccination as part of prevention. And second reason is that the medical doctors everywhere hesitate to do this job, just to do this job. So we had a discussion at the Austrian Health Forum the first day. We were joined about exactly this problem as well. And one of the outcomes was if we would implement into the vaccination a part of prevention systems like microbiome checks and other checks of modern prevention medicine, it would be much easier to cope with the challenge of prevention and vaccine as a part of prevention, not just vaccine. So this is perhaps an answer about the meta question.
So to see if I've understood the question that you're asking, you say that it's within our hands to address it, but you mentioned doctors not wanting to vaccinate. I'm not sure I fully just to vaccinate.
A medical doctor gets 15 euro from the insurance company for his vaccination. They are not interested in it.
You're saying it's not lucrative for the doctors to vaccinate, is what?
This is one of the big hesitations, etc., that vaccine is accepted. So you have the fear, the problems with the child, with the patient, and on top you don't earn anything, and you have also the responsibility. So to put, as we have to transform anyhow the health system in general, this is the meta theme of this Congress, and was already a meta theme 2020 in Davos, for example.
Okay, thanks. So I think, the root of what, if I'm understanding, is really around incentivizing to vaccinate and against the various challenges or maybe lack of incentive. Okay, so I've got 6 questions written down. I don't know if anyone wants to take a question that was directed at them first. Any volunteers to go first? Shall we do? I just didn't know if we have any more. Yeah, well, let's go ahead and take it. Yeah, I just thought then more questions will come. Okay.
Anita Galic from Croatian think tank for healthcare, Health Hub. I have worked on many multi-stakeholder projects regarding the vaccine hesitancy, where we did many public health campaigns on fighting vaccine hesitancy, speaking in favor for immunization by WHO Commission, Sick Fund, Public Health Institute, etc. And most of the campaigns were also included with the digital communication, reels, videos, leaflets, etc. But most of the time, when you write affirmative message about vaccination, then you have, I would say, a fire of anti-vaxxers below in the comments. And there is no probably a capacity of none of the institutions to reply to all the messages. So my question is actually how we plan to develop the skills of the workforce to fight against vaccine hesitancy on social media, because we're definitely under capacity for this. And does this Jitsu Vax amazing project, Complements, is planning actually to develop recommendations or tools for digital communication for HCPs?
Thanks a lot. And I think, I see another, but I'm not sure. I never know where to cut off the questions and to take, I think we can take some responses already, and that doesn't preclude us from having more questions after. Do you want to, is it a quick question? Yeah, great.
It's a quick question.
Yeah.
To me, it boils down to risk communication regarding COVID. I found some good information that actually helped me a lot in showing people why they should get the vaccination. It would be great to have this kind of information especially in absolute numbers, for the, let's call it the older vaccinations, because this is something that really helps people to understand why it makes sense. So tools to actually apply it and show it on a picture to say, this makes sense because there's 100,000 people, there's 100,000 people here, we do this, we don't do this, this is the result. This works better. We know that absolute risks are far easier understood by doctors as well. So.
Okay, great. Thank you so much for that. Okay, so let's, and you can still, again, bring in questions, but let's go ahead and answer, because we've got 8 outstanding questions right now. Anybody want to take a first go, or you want to be reminded of some of the questions?
Well, I can try.
Yes, please,
and
Mira.
maybe answer to my questions. One of the questions I don't know the exact formulation of the question, but I think it was connected to the mandatory vaccination in the communist period. What I would like really to share with you, the situation then and now cannot be translated. It's almost a completely different situation. Now we have the internet, we have human rights, we have the possibility to listen to both sides, and whoever is, let's say, more efficient, whether it is the truth or the lie, he will be more successful. When I was younger, and in that period, we did not have the means for comparison. So it's true, it was communism in the political sense, but when we are talking about the public health and health in general, there were some of the things that were really good and important for the general population. First of all, the healthcare services were for free. Second, the prevention was one important part of it. And I think, as you know, Andreas Stampar in 1948, one of the pioneers of public health, was the person that really stressed very much public health and how important it is. Now, we are in a different situation. But I think we and the experts from public health and also the scientists and the data that exists should have one voice. Especially when we are talking about the vaccination with COVID-19, when there were some informations and not all scientists and all public health professionals had the same opinion on that. And I think there started the mistrust, the misinformation, and as I have already said, it is a very difficult time for the healthcare workers when we are talking about vaccination. Then I would like also to come to the second question, which is connected to the grandparents and the grandchildren. Again, the grandparents were more influential in the previous periods, and they would guide, let's say, their children and what to do with the grandchildren. Today, you know, the young couples, they want to decide for themselves. They don't even trust the doctors. Imagine if sometimes they will trust their parents or something. So unfortunately, these young couples and with children, they should ask themselves, was I vaccinated? Yes, I was. So why I don't want to vaccinate my children? And I think the biggest problem started with MMR and actually and autism. And then the second problem is the vaccine of COVID-19. So prior to that, I don't think there were so big problems. But I would also like to use the opportunity to mention that at the beginning of June this year in Tirana, we had a plenary meeting of the Southeastern Europe Health Network that was devoted to cross-sectoral collaboration for better emergency response, improve vaccine acceptance, current trends on hesitancy, and possible solutions. We had, of course, a wide participation from our partners, WHO, IOM, Central European Initiative, Council of Europe, the European Directorate for Quality of Medicine, and others. Among many factors that were found that impact or determine the vaccine hesitancy, the Southeastern Europe Health Network member states highlighted the big impact of misinformation.
Yeah.
So I think, I don't know if I covered the answers. And
Thank you. I'm conscious of time that it flies. So I don't know, organizers, exactly what time we started, since the session before had run over. But I think we're essentially at time. So what I want to do is give the floor to each of our other speakers to address some of our outstanding questions and maybe see if there are any take-home key messages that they want to leave with the audience. So is there anyone who'd like to go first?
Yeah, I can.
Great. Okay, thank you, Caroline.
Just to, I hope I remembered everything with regards to the, training the teachers. That is. Yeah, of course. And I think in WHO that is happening in the sense that we have this collaboration, we have, this what I call this immune patrol, and this curriculum is built in. I don't know in how exactly they work with the education sector, but the idea is that it's a curriculum that you don't per se have to adjust your normal curriculum, and that the teachers can easily, use it. So it's very friendly towards teachers' understanding on how to work with it. With regards to the elderly care, I think it's a very important point. And as I heard before we went into the panel, you cannot say, I don't know, but I will say it's a very good question. I can just say that, and this is an assumption based on what I've seen myself, that in the country that I work in Belgium, one of the things they did is they started with COVID vaccination in the elderly care setting to really, and work with the elderly care providers to increase the confidence for the people in the homes. So I suppose this happened in other European countries, but I'm not sure about this. And then the last point with if you see shifts from, with your example from France to West Africa, it's a good point, and I believe definitely, pardon, it's not COVID, that yes, in social classes they influence. We also saw that, with the COVID vaccination, there were even my own friends, who come from, I don't know, maybe I shouldn't say political, but left-wing, educated. Suddenly we started to have discussions on, this COVID vaccination, it's a whole new social class that you didn't expect would be against vaccination emerged. So, and this indeed translated across borders. We've seen that Belgium, the Netherlands, and the same social class. So I think it could be also interesting in another European project to take this on. So, of course, for a take-home message, I would say for WHO, it's very high on the agenda for the European region, but of course also for our global level and the other regions. So this is a topic that is close to our heart, and we work together with our other UN agencies and governments to make sure that it will never be forgotten. Thank you.
Thank you so much. And I do think this idea of vaccine acceptance and demand is an important one for kind of shifting the conversation on vaccine hesitancy. So yes, Danielle and
Yes.
And Angelo.
There was one question from online about the Ukrainian-speaking population in Poland. And what we see is that this population comes from a country, Ukraine, where the vaccine uptake is very, very low, and the trust in governance is also very, very low. And they, we initially started with the migrant population, and they move towards Poland and go back for the vaccine uptake. And Poland is somewhat higher in the vaccine uptake and trust maybe, but not that high. But what we saw in relation to COVID is that the Polish government really was looking forward to our results. And as soon as we could share some of the results, especially the health system barriers that existed in this population, they tried to address the barriers already before we were so far with the intervention. So that is, I think it's, well, terrific that the Polish government was open for the results and tried to increase vaccine uptake regarding COVID.
Thank you very much. Okay.
Yeah, and it was one for me about social media, and yeah, we try it. We try to develop a computational model to classify tweets based on the roots, but we did this with some very skilled people from the Max Planck Institute, and oh my God, it was so difficult because tweets are a very bizarre literal genre. People speak write very weirdly, and they mix a lot of ideas, and it's very, very, very tricky to classify tweets from a linguistic perspective.
You need the AI models.
Assuming
throw
that
them in
that is language.
ChatGPT and see what happens, no?
But now we're trying another approach, trying to classify writing expression of anti-vaccination arguments, spontaneous expression. Is more promising, is working well. Maybe we could be able to extrapolate that to the context of social media. That is in our radar, and we will try to do it for sure. Also try to use empathetic message on other domains of disinformation, maybe for politics, for alternative medicine. Yeah, it's also on our radar. We're trying to, I'm having a project on that, alternative medicine and empathetic message with the University of Lima in Peru. And yeah, we hope to have very, very cool data on that very soon. Yeah.
Yep. Wonderful. Well, thank you so much. I know we're over time. I would love to stay here personally and keep talking about this because I think it's very interesting. But I'm aware that you probably have wonderful social plans for the evening and a well-deserved break from lots of sessions and conference thinking. So thank you so much for being with us. Thank you again to our fabulous panel and for all the information you shared. Thank you to Lina for manning the desk. I'm afraid we may have left questions online. I'm not sure, but apologies to our online audience if we did. And I hope you got the QR codes. You can follow up on what these projects are doing and catch us over the next few days at the conference if you'd like to continue the conversation. And thank you very much.